So next we're going to cover active surveillance. Active surveillance is the new standard of care for basically all men with low risk prostate cancer, except in very unusual circumstances. Active surveillance recognizes that most prostate cancers grow very slowly over years and over decades, and therefore that the window of opportunity to cure prostate cancer is measurable in years or in decades. Now, surveillance is not the same as watchful waiting. Watchful waiting is an older term which we would use for men who have a lot of heart disease, for example, and a limited life expectancy. And watchful waiting would say, go home and don't worry about this. If in the unlikely event you show up with bone pain or metastases down the road, we can slow down the cancer with hormonal therapy. Surveillance is very different. Surveillance recognizes that the window of opportunity is very, very long, and that we can potentially defer curative treatment like surgery and radiation for years and not miss the window to cure. So we watch the cancer and defer surgery, radiation, or other treatments until we have some evidence that it might be getting worse. And then we treat with every intention and expectation of still curing the cancer. And this is why surveillance needs to be active. We want to make sure that we see evidence of the cancer progressing well before it is too late. And we typically can do that. And as I said, surveillance really now is the standard of care preferred for nearly all patients who are diagnosed with low risk disease. So that's grade group 1, and especially those with relatively low volume. So who's a good candidate? Almost everyone, as I said, with low risk cancer. So that's clinical stage 1 or 2 and Gleason 3+3, ideally PSA under 10. But as I mentioned in the previous section, if you have a high PSA, just because you have a really big prostate and your PSA density is low, then PSA really should not be an exclusion for doing active surveillance. And almost everybody with 3+3 is at this point a good candidate. Now, there are exceptions. If you've got 10 cores of 3+3 in the setting of a really bad family history, your father and brother both had high-grade disease or died of the cancer early in life, obviously there are going to be exceptions, but almost everyone with low-risk disease at least can choose surveillance initially. We're increasingly focused on those who have intermediate risk cancer and are also very good candidates. So those with the Gleason 3+4, particularly the favorable subtypes of 3+4 that we discussed in the last section, the fused gland and poorly formed gland subtypes, especially where there's not very much pattern 4, these men are also very good candidates for active surveillance, acknowledging that there's a higher risk that they're going to need treatment at some point in the future, but still, that time may be years down the road. And age is not necessarily a factor either. There's still a perception out there that young men really should go straight to treatment because they've got so many years in front of them. Look, this is not true. As a young man, you definitely can do active surveillance. Understanding you may need treatment in the future, but I would much rather have my prostate operated on or radiated at age 63 than 53. And frankly, I'd rather have it in 2023 than 2013 because treatments are constantly improving. Now, do we need additional tests to qualify a man for active surveillance? Yes and no. I think we want to make sure that we have taken a good look to make sure we have not missed some higher grade cancer, because we do know that at the time of diagnosis, there are still 20 to 30% of men who have what looks like low risk disease at the initial diagnosis, who are found in the first year to have something worse because the original biopsy just missed it. So we do look at the PSA density that we described last time in the last section. That's the PSA, again, divided by the prostate volume. Imaging really needs to be done at a high quality center, and that is either a high quality transrectal ultrasound or an MRI done at a place that knows what they're doing. There's huge variation in quality out there in terms of how MRI of the prostate is done, and this really does need to be done at a center of excellence. If we are on the fence, if we're kind of on the edge in terms of whether a man is a good candidate for surveillance or not, for example, there is pattern 4 present, or there's a lot of pattern 3 in a younger man, then genomic tests, the ones I discussed in the last section, like Decipher, can be very helpful as tiebreakers. Now, it's also very important that a confirmatory biopsy be done, especially if the first biopsy was done without high-quality MRI or ultrasound guidance. This means doing an MR followed by a repeat biopsy at a center of excellence like UCSF or a comparable institution, again, to make sure that we have not missed a higher grade cancer, because sometimes we can pretty substantially undersample the cancer on the first biopsy. Now, what does surveillance look like? So we keep an eye on things. Typically, we get a PSA every 3 months for the first year, and after that, we drop the frequency to every 6 months, assuming things are relatively stable. Historically, repeat biopsies would be done every year or two. Today, we are really trying to tailor this and minimize the number of biopsies that we have to do. So we're doing this by looking at the details of everything we've learned about an individual cancer, how it's behaved over time, what the PSA has been doing, whether we have had negative biopsies. In other words, we find a cancer, then the next time around, we don't even find the cancer with a biopsy. That's a very good sign that this cancer is not going to progress. So those with a number of favorable risk factors, we're really trying to stretch out the intervals to biopsy by years. And in many cases now, once we've done a confirmatory biopsy, we're feeling better about the idea of actually replacing biopsies with MRI as long as the MRI is stable and again done at a high quality center with good quality prostate MR. So what's the risk of surveillance? They're frankly low. Every time we do a biopsy, there is a low infection risk. It's under 1%, and we do a lot of things to try to minimize that. There are also low risks of bleeding. Biopsy does not spread prostate cancer. This is a question that comes up all the time. There are some cancers that are so-called sticky and will spread along needle tracts and things like that. Prostate cancer virtually never does this. There are case reports in the literature, but we're talking about a couple out of truly millions, and only the worst of the worst, which we would not be talking about surveillance for anyway. There is a theoretical risk that the cancer can spread to other parts of the body during a period of surveillance, but this is very, 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 very low. If you look at surveillance series with long-term follow-up, about 3% of men that go down the surveillance path ultimately die of prostate cancer. That's very similar to the rates of men who die of prostate cancer who started with surgery or radiation, and it reflects the fact that we do undersample some of these cancers. And also the fact that there are men that start on the surveillance path and really don't get their surveillance interventions. So if you're doing active surveillance, it is a commitment on your part to work with us, work with urologists, and keep an eye on things. You cannot just sort of sail off into the sunset if you've got a good life expectancy, because some cancers do get worse over time. Finally, there can be anxiety associated with active surveillance. I would stress here one thing I said earlier in the presentation, which is that many of us are starting to say that low-grade prostate cancer, grade group 1, shouldn't even be called cancer because we create a lot of anxiety with that C-word diagnosis. We use the word cancer for an extraordinary spectrum of human biology, ranging from prostate cancer at the low end of the risk spectrum to things like pancreatic cancer at the other end. Prostate cancer, on average, is one of the slowest growing cancers, and even the aggressive ones are slow growing compared to most other aggressive types of cancer. And then within prostate cancer, we risk stratify further, and the lowest risk prostate cancers basically never spread. So, part of our job is to work with you on anxiety and try to pull you back from the cliff that many men feel like they're facing. Just because we put the C word on this does not mean that this needs immediate treatment. And it should be a pretty uncommon scenario that we wind up treating a low-risk prostate cancer just because of anxiety. It does happen, but it should be uncommon. Now, how long can you do surveillance? This is in evolution as we have built up longer and longer follow-up in the large active surveillance series. At UCSF now, over 2,500 men have gone down this path since the 1990s. Some men have been surveilled for well over a decade. On average, about half of all men that start down this path are going to wind up getting treated within the first 5 years or so, meaning half of them stay on surveillance. And I would say the trend is keeping men on surveillance longer and longer. And we're constantly refining our approach to surveillance, trying to figure out ways to identify the small subset of men who are going to progress and get them to treatment quickly, and also to identify those who are at the lowest risk of progression so that we can really de-intensify surveillance regimens, do fewer biopsies, and reduce the risk of over-treating cancers, which are otherwise not going to spread.